This week's lecture on mental illness and emotional problems and how we work with individuals that suffer from those disorders is going to be split up into two parts, just largely to make the lectures a little more manageable for you, particularly if you're downloading them onto your smartphone. The first part of the lecture is going to focus upon the the first part of the chapter, which talks about various definitions of what exactly is considered to be a mental illness or an emotional problem of some severity, and also the impact of those disorders upon the lives of the individuals who suffer from them. The second part is going to focus more upon system interventions and things that are successful and not successful in addressing those issues. This week's assignments, I believe, also include Rosenhan's article on being sane in insane places. This article is a very important one, and I know that some of you who have had courses with me previously have read this article. That just tells you how important I think this is in understanding what goes on with human beings. And so if you have not yet read the article in the assignments section of the course, please be sure to do so, because it dovetails very closely with the kinds of things that we'll be talking about here and that you're reading about in the text. First, what is the sort of a definition of mental illness? Serious emotional problems and mental illnesses include various forms of schizophrenia and other mental disorders that are characterized by hallucination, disorganized speech and thought processes, and grossly disorganized behaviors, including such things as catatonia, flattened affect, and other symptoms that may impair the client's work, relationships, and self-care. That's a pretty big mouthful in order to describe mental illness, but really this field encompasses a lot of different kinds of disorders, and so this pretty generally addresses most of them. Now, one thing that's important to understand when diagnoses are made, some mental illnesses are considered to be severe or chronic, and others are considered to be transitory types of mental illnesses, such as adjustment disorders and those kinds of things. And so the focus really of this chapter and this discussion is upon those more serious forms of mental illness. Also, I will point out to you that the DSM-5 has now come into effect, and so this lecture is a little outdated already, because the DSM-4 is really not the diagnostic manual that's being used any longer. The DSM stands for Diagnostical and Statistical Manual. The DSM, the Diagnostic and Statistical Manual of Mental Disorders, and it is now recently in its 5th version. But back to the DSM, the DSM-5 has introduced some changes in terms of how we organize our thinking about some of the mental illnesses, and I believe I've been told has actually added a number of new diagnoses. I think the original intent was, when starting out this revision, was to reduce the number of psychiatric diagnoses and tying more of the disorders to physical ailments, which is probably where they all have a root to begin with. But the project obviously was unsuccessful in that regard, and now we have more mental illnesses. But the DSM-4 indicates that mood disorders include major depressive disorders that last 2 weeks or longer with evidence of symptoms of depression. Now, this is just one of the disorders. And there are several different kinds of disorders other than major depressive disorders. Dysthymic disorders, and that's which depression has lasted longer than 2 years. And I actually think that the first paragraph is probably wrong, and I think it's major depressive disorders lasting 2 years or longer, not 2 weeks. Everybody can get down for a couple of weeks, right? So dysthymic disorders, and dysthymia is another word for depression, and so you have dysthymic disorders, you have bipolar disorders, where there's a combination of depression and sort of heightened and expansive euphoria. That's called mania, and so there's a combination of depression and mania that's called bipolar disorders, and this is I'm just going to mention to you, is a very popular diagnosis among psychiatrists and psychiatric institutions, I've noticed, and a lot of people that go into psychiatric hospitals come out with a bipolar diagnosis these days. And in the course of your career, if you're working with individuals who are engaged in the mental health system, you're going to find, and I'm standing on my soapbox here, but you're going to find that there are chic kinds of diagnoses. There are waves of particular kinds of diagnoses that you will see from time to time. At the present time, bipolar seems to be kind of prominent. This is how a lot of people see a lot of the things that are going on with individuals when they go into psychiatric institutions. And so oftentimes they leave with medications that's supposed to help stabilize the problem. And I'm not sure that those diagnoses are always correct. And so the medications may not always be effective. Cyclothymic disorders are similar to bipolar disorders, but it's a more or less a milder form. I mean, just to kind of oversimplify it, a more mild form of bipolar disorders. We all have mood swings, and so that's not to say that a typical mood swing is something that constitutes a mental disorder, even diagnosably, or diagnosably is the word that could be called a mental disorder. Mood swings, that's not what we're talking about here. We're talking about things that are pretty pronounced and long-lasting, and that really create problems in the individual's life in terms of their ability to work or attend school, maintain successful and healthy relationships, etc., etc. Here are some statistics about serious emotional problems. It's estimated that a little over a quarter of Americans 18 and older suffer from a diagnosable mental disorder in any given year. About 6% of those people suffer from a serious mental illness. So you see there the majority of individuals that are getting diagnosed with a mental disorder are being diagnosed in the less severe kinds of categories, like I was talking about with adjustment disorders, for instance. Mental disorders are the leading cause of disability in the United States and Canada for people aged 15 to 44. And where this comes from, my guess is probably from disability determinations and Social Security and other such things like that. And oftentimes people have more than one mental disorder at a time. And here are some of the things when you talk about mood disorders. Now, we had looked at depressive disorders. Now let's talk about mood disorders. Here are some of the major categories of mood disorders in DSM-4. Again, I'm talking about major depressive disorder, dysthymic disorder, bipolar disorder, and suicide, which isn't really a diagnosis, but it's a behavior that kind of results sometimes from these disorders when they get out of control. And you see that there's quite a number of people that commit suicide in the United States every year. Young males, we often think of young males as being particularly susceptible to this, but you see here the highest suicide rate in the United States are found in white men over age 85. Now, is that a surprise to you, perhaps? But that just goes to show you that some of the effects of, and we'll be talking in another week or so about working with the elderly and some of the effects of getting older and the isolation that may ensue and the losses that ensue as one gets older and older in today's society contributes to that. It's of note, by the way, worthy of note for the purposes of our class, and in Alaska, the suicide rate among young Alaska Native males is, the last I heard, about 5 times higher than the suicide rate for young males of the same age in other parts of the United States. So it's a particular problem among Alaska Native populations as well. 4 times as many men as women die by suicide, but women attempt suicide 2 to 3 times as often as men. I have heard those statistics be a little different, that men actually commit suicide 5 times more frequently than women, but women attempt suicide 5 times more frequently than men. Whatever the actual statistics are, it kind of gives you the sense of why what happens there. And one of the beliefs that I think that we have about that in the field has been, at least all along, that the means that men use tend to be more lethal than the means that women tend to use. Men tend to use weapons and guns, which is much more of a final kind of effect than individuals who overdose with pills and those kinds of things. So whether I would add this here in this particular discussion, by the way, that whenever you have someone tell you they want to kill themselves, that should always be taken seriously, whether it's a child, whether it's an adolescent, male or female, somebody who's appeared to be depressed or somebody who seems to be particularly happy. Because oftentimes once an individual has made the decision to actually end their life, their spirits lift and they actually begin to feel better. A lot of people will tell you, that, having been around individuals who've committed suicide, that they're so surprised by this because he really or she had really been looking so much better over the last few weeks. And in fact, what happens sometimes is individuals finally make the decision they're going to do that, and they do feel better. But that doesn't mean that they're not still thinking lethally. And so, in any event, my point here is that whenever an individual tells you they're considering suicide, don't brush that aside. Always take it seriously. Major depression is a pretty significant problem here. You see that about 10% of the United States, the adult population in the United States, has some sort of depressive disorder. This tends to be more heavily women. About twice as many women as men are affected by some form of a depressive disorder. This makes sense when you think about how we socialize. Boys and girls, that boys are socialized to act out and to carry on more than girls, who are taught to act in, so to speak, and to keep their upset inside and to themselves. And so this is going to lead to more depression. And another interesting aside for you, and one of the not major disorders you'll often have if you work with children, is you find individuals with conduct disorder. Adolescents are often diagnosed with conduct disorder that become if they continue to have that diagnosis as adults, that becomes the antisocial personality disorder. But conduct disorder really covers, and oppositional disorder sometimes covers a lot of just a wide range of behaviors that involve acting out adolescence. More frequently, boys than girls are diagnosed with this, again, because girls tend to have more of the depressive diagnoses. But boys who are acting out are really sometimes very depressed themselves, but they have been socialized away from acknowledging and recognizing those feelings in themselves. And so when you work with boys that are acting out, and again, girls as well, but particularly boys in this, for the context of this discussion, it's worth considering that probably underneath the surface, if you kind of peel back the layers of what's going on, you're going to find a depressed kid inside. And if you can really reach to that and get to that in working with acting out adolescents, you'll do a world of good for them and help them begin to identify and to express their feelings appropriately. The average age of onset of depression is in the mid-20s, but there is an early onset depression among children that's seen fairly commonly among those of us who've worked in the mental health field, and again, oftentimes is missed because we have sometimes a tendency to diagnose the superficial. That is, with boys who act out and who are oppositional, we see them as conduct disorder rather than really looking and getting to know what's going on inside of them. Bipolar disorder that we had talked about earlier also impacts about 10%, according to the diagnoses, at least, that we get from professionals in the field. And oftentimes you'll find depressive disorders co-occurring with anxiety disorders and with substance abuse as well. This is another area in substance abuse treatment. Although most individuals will tell you have to deal with the substance abuse first, you have to resolve that issue first, you're going to find the substance abusing clients often suffer from depression or anxiety, some form of mood disorder, and they're self-medicating. And so don't overlook that factor when you're working with substance abusing clients as well. People tend to be a little older before mood disorders surface, but again, that's an average age or a median age, and it can come at any age, really. Now, the severe mental disorders, and these are the things that involve some elements of psychosis where people actually lose touch with reality and have hallucinations, sometimes may hear voices, have delusions and those types of things. One of them here, perhaps the one that we're most familiar with, is schizophrenia, and about 2.5 million American adults really have been diagnosed with schizophrenia. That's about 1% of the population aged 18 and older. Schizophrenia is not diagnosed in children for a number of different reasons that we just don't have the time to go into here, but there are sometimes symptoms of sort of the early signs of developing schizophrenia that professionals will sometimes identify called prodromal symptoms. But schizophrenia is only diagnosed at age 18 or later. When it usually surfaces, if you accept the traditional definition, at least, of schizophrenia and all of that, it tends to be late teen years, early 20s. That is around the time of breaking away from the family or going into their adult lives or into college or whatever. And there are a number of different theories about schizophrenia. Most recently, more and more evidence points towards a biological basis, and there's some brain mapping that is going on, those kinds of things that I believe are some very promising results there that may give us the possibility of actually being able to identify the physical cause of this disorder. And so, as it is over time, more and more and more of the things we don't understand, we come to understand, and we can treat more effectively. And I think many of the major mood disorders and major psychiatric disorders we're going to find have a medical base, and that we will be able to treat medically as opposed to, through psychiatric interventions and things, once we come to understand them better and realize the causes of them. So one of the explanations for schizophrenia, at least at this time, is that it is a physical thing that has something to do with with the brain and those kinds of things. But there have been a variety of explanations for schizophrenia and where it comes from over the years. Back in the 1950s, among other things, when we were trying to keep women in the home and keep them out of the workforce, we were talking about mothers who work, who set up schizophrenic children, or mothers who give mixed messages. They were referred to as schizophrenogenic mothers that basically were thought to drive their children crazy and into schizophrenic states. So these things aren't accepted any longer, but it does show you that there's been an evolution of beliefs and thought about schizophrenia. In the 80s, some of the individuals, the family therapists who were into systems theory, believed that the schizophrenic young adult really was servicing an unhappy marriage among between his parents or her parents, so that the individual, this was, I think, Jay Haley's theory. In fact, he wrote a book called Leaving Home, which was a very interesting book, and his theory in there is that as the young person, oftentimes the schizophrenic was the youngest in the family too, by the way, and so leaving the home and knowing on a certain level that his parents have a very unhappy marriage, what the schizophrenia did, what the psychotic breaks did, really was keep the parents focused upon their adult child, so that they could continue to avoid dealing with the unhappiness in their marriage, and so it would service the marriage in that way. Now, again, that's sort of that's a very strong theory, but again, I'm telling you that more and more the evidence points to a medical basis for schizophrenia. Another condition here that's listed under mental disorder is Alzheimer's disease with dementia, generally associated with older Americans, where they're looking very closely at finding the physical genesis of that disorder, and hopefully there will be some advances made in this area in the next few decades. Another group of major mental illnesses includes anxiety disorders, and here you see a list of a number of different kinds of diagnoses that you'll see. Panic disorders, for instance, where a person may be just kind of going about his or her day. This, I think, tends to be more frequently diagnosed with females, but it can be diagnosed with males as well. But that for some reason, all of a sudden they begin to have a panic attack, and their breathing begins to become very rapid, and they're perspiring, and they feel like they're going to pass out or even die because they can't catch their breath. Sometimes, those individuals actually do pass out, and of course their breathing goes back to normal when that happens, so they don't actually die, but we don't necessarily, you can't exactly put your finger on the reason for the thing what is that prompted that panic attack. And so there's a lot of, I talked a few weeks ago when we were talking, I believe, about sexual abuse victims and post-traumatic stress, that there are a lot of us who believe that there may be just subtle cues, smell, the sounds, the way a light bounces off a table or something like that in the back of the mind reminds the individual of some repressed memory that was particularly frightening that they have managed to push aside. You know, but again, that's just another theory. There are physical causes, oftentimes, or physical roots that are suggested as well. And you see other kinds of disorders, phobias, and post-traumatic stress disorder as well, all listed in anxiety disorders. Says about almost 20% of people as adults have an anxiety disorder of one type or another during any given year. And usually there's not just one anxiety disorder, but there's a complex of disorders at least. But this is another area that's very interesting to work with individuals that suffer from these problems. Eating disorders, probably tie some into anxiety disorders. And while I think there are more adult males now being diagnosed with eating disorders, this is an area that has been heavily dominated and diagnostically, at least by females. So that and that again ties in, I believe, to socialization methods. The prisons may have a lot more males in them because they're criminal and they're acting out. Hospitals will have more female victims of eating disorders for much the same reason. I believe it's about socialization, and so teaching our girls to maintain control and to keep their feelings to kind of not act out and not be angry and aggressive all the time, and those kinds of things can lead to one kind of turning anger upon oneself, becoming very depressed, and eating disorders oftentimes have a role to play in that, or that has a role to play in eating disorders, whether it be anorexia nervosa, bulimia, or binge eating. Anorexia, the person really literally is starving herself or himself, but herself probably, and that's very often a fatal disorder if it's not treated properly. It's a serious disorder. Bulimia is similar to anorexia, except the individual tends to eat, but then will purge, go to the bathroom afterwards, and make herself vomit. And that creates a lot of other problems aside from the health issues as well. And binge eating, of course, is overeating and those kinds of things. So you see here that between 0.5% and 4% of females suffer from anorexia, and a little bit more than that suffer from bulimia. And you see we're talking females there. 2 to 5% of Americans experience binge eating disorder in a 6-month period, and you see it has a pretty high rate, a pretty high mortality rate. It actually says that the mortality rate for anorexia is about 12 times higher than the annual death rate due to all causes of death among females between the ages of 15 and 24. You see, this is a major problem for females of that age. Another disorder that working in the field you'll become very familiar with, and I also suspect is misunderstood, although I don't know that anybody has the answer for it, but it's attention deficit hyperactivity disorder. And there is attention deficit disorder without hyperactivity also. It's just called ADD, but ADHD has that hyperactivity element to it, and it is a very common diagnosis among children and adolescents. It has gone through a period of time where it was the popular diagnosis for quite a while, and I believe it was overdiagnosed. I think it was incorrectly diagnosed at time, and sometimes kids have been put on medications for this that really are not suffering from ADD. But that's my opinion. It's just something we have to be very careful about, because the symptoms with ADHD are very similar to other kinds of symptoms, including just the behaviors that happen to be displayed by children who grew up in neglectful homes. But in any event, ADHD also is an adult disorder and affects about 4% of adults, and those adults generally find themselves unable to attend to anything long enough to complete a task. No, this is not you're out here as far as not getting your homework done in class or anything, but ADHD is a real diagnosis for a large number of people, although we usually see it surfacing more frequently in childhood. It also produces a lot of problems in relationships, because part of the impulsiveness that comes with ADHD these children in particular become very intrusive in relationships, and they interrupt constantly and demand attention constantly, and to the point where people don't like them oftentimes because they just don't have the capacity to wait their turn, for instance, in a conversation, but just kind of butt in, and so they just don't have the capacity to kind of share equally in social interactions that most young people do. Autism, in my opinion, is the latest kind of way of seeing things. I guess I want to call it a chic diagnosis again, and I apologize for those of you if you feel as though I'm being unnecessarily cynical about mental health diagnoses while I'm talking about them, but we just have to be very careful about diagnoses, and I'll talk about that in a minute. But autism is a increasingly diagnosed disorder. That doesn't necessarily mean we have more autistic children. It may mean that a lot of mental health professionals have gone to trainings on autism, and all of a sudden, well, you know the old saying that if the only tool you have is a hammer, after a while, everything starts to look like a nail. It's not exactly that. It's not to say that the mental health professionals who diagnose autistic children don't have other hammers, other tools. But sometimes when this is sort of the big training thing going on, this is what everybody begins to see, and the sort of filters that are put on everyone's thinking about children. And so I think that may have some explanation for the increase in autism diagnoses. There have been some people who have maintained that childhood immunizations were tied to autism. I think that has been dispelled now. I believe that there's scientific evidence out there enough convincingly now to convince us that that's not the case. But some people who avoid immunizations still believe that. But this is a group of disorders that are generally known as autism spectrum disorders, or pervasive developmental disorders. You oftentimes will hear of Asperger's syndrome, and Asperger's has generally been considered or thought to be kind of a milder form of autism, where an Asperger's, the child, at least generally, is a child with that diagnosis, I think, that really kind of has social oddities and really can't relate to other people, kind of isolates a lot, and just is very awkward socially. Doesn't relate to not only people their own age, but doesn't relate to adults either. And when they do relate to somebody, they tend to maybe connect very, very strongly. And autism is again, in generally speaking, seems to be a much more exaggerated form of that. And autistic children, by the way, as one of the I don't know if this is true or not. I probably shouldn't say this, but I know one of the thoughts about autistic children, I guess one of the theories about autistic children, is that they're highly intelligent, and I just can't think of the term I want for that, but you get the idea. There was a book, one of the earliest books on autism, in fact, I think, that was very popular in the 1970s when I was working on my undergraduate degree, called Dibs in Search of Self. And I remember reading that book. And what do you think they blamed autism on in those days? The moms. Once again, it was the mother who was kind of cold and detached in that book, and just couldn't express her love and affection for her child, and so Dibs kind of pulled away, and had his own little world, and had his own needs met within his own mind, and those kinds of things. And there's, of course, we don't blame mothers anymore for this, but this is another one of these things that I think we don't really understand, and as time goes on, perhaps we'll reach a better understanding. I hope you are able to be working in the field when we reach an understanding of this disorder and can treat it for what it is and not for what we think it is. So just a few slides here to tie up this particular part of the lecture on the impact of serious emotional problems. About 3 million Americans have an emotional condition that affects their ability to work or to seek educational opportunities. And about 2 million have symptoms of bipolar disorder every year. And Sometimes this involves a lack of will to live, or emotions that seem to be out of control, that kind of thing. About 15% of persons diagnosed with mood disorders commit suicide, and two-thirds of those suicides are preceded by episodes of depression. Clients who have a depressive disorder take 3 times the number of sick days in a month before the illness was diagnosed than coworkers who weren't depressed. So this is not only about an individual thing, but this has an impact on the work site and the client's capacity, or the individual's capacity to perform productively during the day. Again, we all need a mental health day sometimes. We all want to take a day off. We all feel down sometimes or something like that. This is not what we're talking about here. Depression is the primary reason for disability and death among people up to age 44, adults. And there's one study here that showed that about 1,500 participants that had no history of heart disease for 13 years, those with major depressions were 4.5 times more likely to have serious heart attacks than those without episodes of that depression. So it has an impact upon the body and how the body functions as well. People with mental illnesses are more likely to be unemployed, have less income, experience a diminished sense of self, and have fewer social supports. People really find them sometimes very difficult to be around, don't always know how to deal with them, and so may avoid them. And so the individuals, because of their inability to function as successfully as others around them, perhaps, and perhaps because of the strain in social relationships and the scarcity of relationships that are truly supportive, it has a major impact upon one's self-esteem. And so, well, we'll talk about interventions in a few slides, or in the next lecture rather, but mentally ill persons may expect and experience rejection in part because they think less of themselves, have limited social opportunities and resources, and because of the severity of their illness. And we'll talk in the next lecture about how the intervention sometimes for individuals with severe mental illness is really to pull them out and to get them interacting and keep them interacting, and sometimes that's the best treatment for this. So I just want to say before we leave this particular lecture, and again, to remind you to be sure to read Rosenhan's article on being sane in insane places, because again, it's a very important thing, and it's an article about individuals in mental institutions. Now, mental institutions still exist, although there are fewer and further between than there used to be. That's a part of the next lecture. But even outside the mental institutions, as this slide and the last few slides have suggested, when an individual has a mental health diagnosis given to them, that's a label kind of hung on around their neck or on their forehead or wherever it might be, that can become one of the things that we define that individual by. And as professionals, if we define our clients, kind of categorize them and lump them into these categories because of these diagnoses, our clients are going to see us treating them just like everybody else treats them in the world, and we're going to be less effective with them. And so when working with individuals with mental health diagnoses, it's important you may want to know what the diagnosis is. Certainly you want to know what the diagnosis is, and it's certainly important to understand what that says, but don't let that convince you that this is the limitation on this client, or that this client can't function more successfully, or that diagnosis is who the client is. It is something to do with perhaps the behaviors and the emotional states that individual experiences or displays, but it is not who the person is. And remember that there's a person there that has strengths and things that you can do, or things that you can tap on in order to help that person function more successfully in the world. We can't be blinded by diagnosis. I've had individuals that I've worked with and who have mentored me who have insisted that psychiatric diagnoses is harmful and abusive to clients, and 100 years from now I suspect we're going to see that's the case. That this was our poor attempt at almost witch doctoring, in a sense, that we didn't understand what was going on with clients. And just like clients used to be locked away in mental institutions for their whole lives and subjected to horrible things that we now know is like totally inhumane, 100 years ago that's what they did. And 100 years from now, what we're doing is probably in the area of mental illness is probably going to be seen in something of the same light. And so what I want to say to you is, remember that your client, no matter what the diagnosis is a real human being. Try to look past that diagnosis. Don't be overwhelmed by the diagnosis, but work with your client as a human being with his or her own strengths and his or her own weaknesses and issues. Address the concrete things in that person's life, and you'll probably do far more to help that person than you would otherwise. Okay, so off my soapbox and ending this particular part of the lecture, part 2. Get some coffee, take a break, and come on back and listen to the next part. Thank you.